Thank you for the organising committee to invite me. It's a great honour for me to come along and talk. And as was said in the introduction, I'm a medical oncologist, and I've been in Oxford for about 17 or 18 years now, treating patients with urological cancer, so kidney cancer, bladder cancer, prostate and testicular cancer. And today I'm talking about a change in paradigm in the first-line treatment of metastatic renal cell cancer. I have no disclosures. So the topics that I would like to talk about are here. So it's really about understanding the biology of the disease and understanding how it's changed over the last 10 years, and then talking really about some of the evidence for the tyrosine kinase inhibitors, newer generation tyrosine kinase inhibitors, and then actually some of the newer treatments that are going to revolutionize and change the practice and change how we treat patients and change what we have to offer. And the timelines have really been over the last 20, 25 years, from the treatments that we had in the 1990s to where we are in the mid-2000s to where we are today. And actually managing kidney cancer or metastatic disease has been a very exciting time over the last 10 years with all these newer agents and newer drugs and newer treatments that we have on offer. So the story really starts from 1993 when the VHL gene was identified and published. And as we know, that gene was identified in patients who had von Hippel-Lindau syndrome, and a characteristic syndrome together with pancreatic cysts, hemangioblastomas, cerebelloblastomas, retinoblastomas, and various different tumours, but they also developed kidney cancer. And what's particularly interesting is they developed clear cell renal cancer. And then it was understood that even in the sporadic cases of clear cell renal cancer, the VHL gene was mutated. So suddenly we had a gene mutation within renal cancer that in some part could explain the biology of the disease, but equally we could develop treatments that were designed to target some downstream effects of this mutation. So this slide really talks about what VHL is. And you can see here the VHL protein, and you can see it bound to HIF, which is hypoxia-inducible factor. And in normoxia, in normal oxygen conditions, proline hydroxylase gets oxygenated and is able to bind to the VHL protein, which has enabled the HIF protein to be ubiquinated and targeted for destruction. So in normoxia, the VHL protein is very important in actually this process of breaking down HIF. But if you have hypoxia, oh sorry, I'm pressing all the wrong buttons. Let me just go back. There we go. In hypoxic conditions, proline hydroxylase doesn't get oxygenated. HIF is then constitutively active, and you can see all these downstream effects that are involved when HIF binds to DNA and acts as a transcription factor, and it leads to increased angiogenesis, erythropoiesis, apoptosis, cell proliferation, all these different effects. And we know that in renal cancer, there is frequent VHL inactivation. Probably around about 90% of clear cell renal cell cancers, VHL is inactivated, some through the genetic, through the gene mutation, and some through epigenetic factors or post-translational factors. And this is a slide showing all the different downstream effects of when HIF binds to DNA and all these different processes involved in cell proliferation, etc. So HIF is a very critical protein involved in renal cancer. The other pathway that's very important to renal cancer is the mTOR pathway, or the PI3 kinase AKT mTOR pathway, and this is also very critical in renal cancer. And what that has meant is that there's been a whole load, a new generation of drugs that are able to target these pathways in renal cancer. And in the 1980s and 1990s, we only effectively had cytokines. We had IL-2 and we had interferon, and they were the mainstay of treatment for 15, 20 years in various different guises, whether it was high-dose IL-2, low-dose subcutaneous interferon, combinations. That was all we had. But then from understanding the biology of the disease, newer drugs were developed, such as the tyrosine kinase inhibitors, sunitinib, pazotinib, etc., and also the mTOR inhibitors, such as temsirolimus and everolimus. And you can see here all the registration of all these different drugs. So suddenly we've been having newer generation treatments for renal cancer, and not only first-line treatments, second-line treatments, third-line treatments. And you can see here that these essentially are our first-line treatments that we are using today, almost today. So sunitinib, pazotinib, tivozanib as tyrosine kinase inhibitors, temsirolimus as an mTOR inhibitor, and we have Avastin or bevacizumab as a VEGF monoclonal antibody, and the older treatments such as IL-2. This slide really makes the point that these tyrosine kinase inhibitors are different. So this is a kinesiogram. It's looking at the kinase interaction maps, and each of these different branches represents a different tyrosine kinase. The red dots relate to where these drugs bind, to which kinase, and the size of the dot relates to the binding affinity or intensity. And you can see that these drugs are different, not only in the kinases that they bind, but also the strength of the binding. And that may lead to different inhibition pathways, different efficacy, and probably maybe different toxicity. And this is also accounts the reason why some tyrosine kinase inhibitors will work when others don't. We also have risk stratification scores. So this is the original MOTSA classification from the MSK, and this looked at patients with metastatic disease who had been treated in the cytokine era with either interferon or IL-2, and it looked at various risks. And the risks they came up with in multivariate analysis were performance status, time from diagnosis to systemic treatment, HB lower than limit of normal, a raised LDH, and also a raised calcium. And if you took these 6 factors, you can actually stratify according to outcome. And it's stratified into a favourable prognosis, intermediate, or poor. And you can see here from the data from 2002 the different outcomes for favourable, intermediate, or poor. And that certainly makes a difference in terms of the studies that have been done on the tyrosine kinase inhibitors, and also in terms of the newer generation drugs as well, in terms of what the aims and the goals of the treatments are. In the modern era with the tyrosine kinase inhibitors, Heng has produced this classification, which is very similar and is built on the MSK classification, and it's just added a couple of newer factors, thrombocytosis and a raised neutrophil count, and it's taken away the LDH. And again, you can see divided according to these risk factors into a favourable prognosis, intermediate, or poor. So these are some of the studies, the randomised studies, the phase 3 studies that have been done on tyrosine kinase inhibitors. And these studies, I've put in a table here. You can see which drugs down this side. You can see the phase of the study. Most of these are phase 3. There's one phase 2 study here. You can see the year, and you can see the number of patients, and you can see the outcomes. The seminal paper, the seminal study was Sutent versus interferon in 2007. And what that study looked at is a very simple randomization for treatment-naive metastatic renal cancer patients, either randomized to have sunitinib or interferon. And you can see that it changed the progression-free survival, virtually doubling it from around 5 months to 11 months. with a much increased significant change in response rate, but no overall survival advantage at that time. The other seminal paper was Cora-Stoltenberg's study of pazopanib versus placebo. This study, when it was presented, was criticised because it was against placebo, but actually patients were able to cross over and they were getting treatments at a later stage with tyrosine kinase inhibitors, which accounts for sometimes why these studies didn't show an overall survival advantage. I'm not going to go into all the details of all these studies because of time, but I might mention the COMPART study at a later stage. So here we have the Kaplan-Meier survival curves from the Sutent versus interferon study. You can see that on the overall survival and the updated analysis, median survival for the Sutent was 26.4 months, and for the interferon, it was 21.8 months. And if you look at the patients who didn't cross over, there was virtually a doubling of survival from around 14 months to 28 months. This was very novel at that time. It was the first access that we would have to a tyrosine kinase inhibitor, and it made a huge difference to the treatment of these patients. So the table looking at the response rates, there were no complete responders. Partial response was 31% versus 6%. And actually in a true randomized study, we were suddenly realizing that interferon wasn't the treatment that we were talking to patients about and offering it to patients. The response rates were very low and it was quite significantly toxic. In the Cora-Stoltenberg paper, this is all patients, and you can see progression-free survival difference of, again, doubling, 9.2 months versus 4.2. And the overall survival difference, there was no difference, and in part because these patients did cross over to tyrosine kinase inhibitors. Tumor responses, again, very low rates of CR, partial responses, 30% versus 3%. So what about toxicities? At the time when the tyrosine kinases came out, we all had to learn about how to manage these toxicities. Some were very similar, such as fatigue, and you can see the frequency of fatigue, both in Sutent and pazopanib. Hypertension was something that was new to us and is a class effect from these drugs. And we as oncologists had to learn how to manage it and how to treat it. And again, you can see that it occurs in around about 30% of patients on Sutent, maybe slightly higher in pazopanib. Diarrhea is another significant effect, and liver dysfunction as well. It does cause some altercation in the blood counts, particularly neutropenia and thrombocytopenia, but generally the neutropenia really isn't a worry. They don't tend to get sepsis from being neutropenic, which is also quite interesting and very different from the chemotherapies that we give. This table really is just to show some of the differences between Sutent and pazopanib in some of the side effects, and that goes right back to that kinesiogram that I showed, that they do have slightly different kinases that they interact with and slightly different binding efficiencies, so their side effect profile is slightly different. But ultimately, we now have two first-line tyrosine kinase inhibitors. We have Sutent and pazopanib. They haven't really been compared directly in a true head-to-head, but both of them are efficacious based on those studies that I've showed you. And we have no guidance really to show whether one is better than the other. Pazopanib may be associated with less fatigue, less hand-foot syndrome, less alteration in taste, and less thrombocytopenia. But Sutent equally may be associated with less liver dysfunction. There were a couple of studies where the company GSK, who promoted and developed pazopanib, wanted to see whether actually one was better than the other, and they did a couple of head-to-head studies. I don't have time to show you all the slides, but I can mention it. One was a COMPART study, and that was a non-inferiority study, not really to show whether one drug was better than the other. It was to show that one drug was no less an alternative to the other, but really to look at the toxicity. The COMPART study didn't show any difference in survival, response rates, progression-free survival, but it did appear to show that the toxicity profile may have favoured pazopanib, and the quality of life may have favoured pazopanib. GSK also did another study, which was a patient preference study, where they randomised patients to either start on Sutent or start on pazopanib, and they were blinded to which drug they were on, and then they crossed over to the other drug, and then at various different time points, they had to complete quality of life studies. But again, that study was designed in the favour of pazopanib, but if you believe the study, it showed that patients preferred to be on pazopanib rather than Sutent, and that preference was around about 70% of patients. So in terms of the tyrosine kinase inhibitors that we have, how do we select them and how do we manage it? And some is around optimizing the treatments in terms of the dose that we're giving, in terms of the schedule that we're giving, and in terms of ensuring that the patient is maintained on the dose, which is about optimal side effect characteristics. Most of everything I'll talk about today is really about clear cell renal cancer. I'm not going to talk too much about the non-clear histology that we've heard about earlier on. There's also patient characteristics which will define which drug we'll use, whether we're more concerned about the liver toxicity, cardiac toxicity, whether patients would prefer to be on a 4-week schedule with 2 weeks off rather than a continuous schedule. But we have both of these drugs available to treat these patients. There have been other randomised studies. This study in particular was looking at the role of temsirolimus, and this was a study in poor prognostic patients. Hence the median progression-free survival and the overall survival was less. But actually this was the first study to show that temsirolimus as an mTOR inhibitor did have a role in poorer prognostic patient groups, and that drug was and is licensed for management of first-line patients with poorer prognostic disease. I don't tend to use that drug as much. And there are a couple of other studies looking at bevacizumab in combination with interferon that again have shown a benefit for that combination over interferon alone. And whilst they are licensed and can be used as a first-line option, I don't think many of us are using it that much today. There's also newer tyrosine kinase inhibitors. So tisotinib is a newer VEGF inhibitor, which again is supposed to be more potent than Sutent and pazopanib. The data shows progression-free survival pretty much like Sutent, overall survival very similar, but it has been licensed as well. And then this newer multi-agent tyrosine kinase inhibitor not only covers VEGF, also covers c-Met and AXL. And I've got a slide just to show some of that data. And again, this study was in poorer prognostic patients, hence the survival and the progression-free survival is less than you'd see with Sutent and pazopanib. This is the data for the TiVo study, and you can see that progression-free survival was 11.9 months versus 9.1, but overall survival very similar. This drug has been licensed and available for use for first-line study. There was a slight problem with the study, is that the comparator arm was sorafenib, and actually even in the day when this study was set up, Sutent, sunitinib, was the preferred choice for first-line treatment, so it's slightly odd to use that as a randomised basis. And when you look at the side effect profile versus Sutent and pazopanib, although it's supposed to be a newer generation tyrosine kinase inhibitor, which is much more selective, actually the toxicity profile is very, very similar. Cabozantinib, this is the study looking at intermediate and poor risk, which was published and presented last year. And this showed, this is a randomized phase 2 study, which showed a significant improvement in progression-free survival for cabozantinib. And this study was based on the Meteor study, which is a second-line study that I'm sure we're going to hear about in a minute. And this has now been licensed and available for patients with poor risk renal cancer. And you can see the response rates, 33% versus 12%. That's the overall survival from the study, which didn't really show any significant improvement. But again, it probably wouldn't, because there are second, third, fourth line agents that we can now use. So essentially, all of these first line agents have been approved on the basis of significant benefits in progression-free survival and response rates, but not overall survival. And that has been confounded by the crossover effect of going on to receive second, third, fourth line agents. So if we think about tyrosine kinase inhibitors, we can say that response rates are around about 30%, with an approximate progression-free survival of around about 11 months. And actually, we can improve on these drugs by managing their toxicities and maintaining their doses. And if we think about the median survivals, you can see there has been a stepwise improvement. So if we look at the MOTSA study, and we can see that progression-free survival is around about 11 months, overall survival 26 months. If we look at the COMPART study, overall survival 29 months, and another study that I've not presented, which is a record study looking at sunitinib versus everolimus, we can see that again, median overall survival 32 months. So over the last 10 years, there has been an improvement. Some of that is about how we manage these patients, selecting the right patients, supportive care for these patients, managing their toxicities. Some of it is about having second, third, fourth line agents available. So if we think about our guidance now, for the European guidance, we can divide it into good, intermediate or poor risk. And for the good risk, we have treatments, sunitinib, pazopanib and bevacizumab and interferon available. If we select out our poor risk, then we are able to treat with temsirolimus. But we do have other alternatives. And I have to say that when I look at this list, the drugs that I mainly use first line as standard are sunitinib and pazopanib. I certainly don't use bevacizumab and interferon, and I don't really use temsirolimus as well. I still use sunitinib for these patients, unless we have studies available. If you look at the American, the USA guidance, it's a little bit more comprehensive than the European guidance, and you can see all these different drugs that are available for first-line treatments of predominantly clear cell histology. How they select them out in the USA, I don't know, but my impression is that they're still using sunitinib or pazopanib first line. So I've got a couple of minutes just to talk about where do we go from here and what's new. That's how we've been treating patients for the last 10 years, first-line tyrosine kinase inhibitors, but we know that there has been a resurgence of the concept of immunotherapy, and now we have lots of studies that are coming through, lots of trials looking at the role of immunotherapy as first line. We all know, and we're going to hear more about the data, about the use of Nivo in a second line setting, but let's look at the first line setting. What's interesting about immunotherapy is we think of it as a novel concept and all these drugs as new drugs. But actually, if we think about the history of immunotherapy, immunotherapy predates the modern use of radiotherapy, and it predates the modern use of systemic chemotherapy to managing patients with cancer. And actually, this chap, William Cooley, who was a cancer surgeon at the Memorial Sloan Kettering Hospital in New York, he was the first to recognize that some of his patients who had systemic infections, which he determined as erysipelas, which is a cutaneous infection mainly of strep or staph bacteria, he first noticed that in those patients who had bad infection, they got a regression of their cancer. So he developed what was called Cooley's toxins to see if actually he could treat those patients. He probably killed more patients than he actually benefited, because he mixed a concoction of different bacteria and injected it into it. But this is his first paper, and if you search the internet, you can still get and download the whole of the paper, which was published in the American Journal of Medical Sciences in 1893. And this is one of the pictures from there of one of the patients who had a spontaneous regression and was alive several years afterwards. So that's the history of immunotherapy, and over the last 120 years it's waxed and waned in terms of the developments and the understanding. But where we are today is we understand that there are significant interactions between the dendritic cells, between tumour cells, and between tumour cells, T cells and dendritic cells, and it all relates to these different proteins on the cell surface and their different roles. The modern day immunotherapies really are interacting with the programmed death receptors on T cells, on tumour cells, and also on dendritic cells. And again, we know from studies in other tumour types of the role of drugs such as ipilimumab and nivolumab, and they have been licensed in metastatic renal cancer patients as a second-line treatment. But as always, when these studies have shown benefit in a second-line treatment, the question is, can we do any better in first line, and do they have a role in first line? And I've got a couple of slides on two studies. One was a Checkmate 214 study that was published, presented initially at the European Society of Medical Oncology in Madrid in Spain in September, and was actually published fully this week in the New England Journal of Medicine. And the other study is the study with atezolizumab and bevacizumab, which are both Roche compounds, Emotion 151, which hasn't fully been published in print. So here's the New England Journal of Medicine paper from this week, published 3 days ago. And this study took patients treatment naive metastatic renal cancer. They were stratified according to their risk criteria, and they were randomized to either nivolumab plus ipilimumab and a lower dose of ipi than is standard for the melanoma treatments versus the standard of care, sunitinib. And you can see here there was a significant overall survival difference. In the suitant patients, overall survival was about 26 months, and it hasn't been reached as yet in the combination paper at all. But you can see this looks very exciting, how the separation of these curves are, and a significant number of patients alive at 12 months and 18 months. I should say that this is the overall patient population, but the intermediate and poor prognostic group did particularly well. Patients with favourable prognostic disease really didn't do so well in this study at all. And when you look at the response rates, very impressive, 42% versus 27%, which is very exciting. If you looked at the PDL expression, again, you could separate out the intermediate poor prognostic according to their PDL expression versus the intention to treat. And actually, if they had a PDL expression greater than 1% on the tumour cells as the cutoff, response rate 58% versus 22%, which is very exciting. And it may well be that we can now begin to look at treating patients with intermediate and poor risk disease along these lines, knowing we have a very good outcome and a very good long-term survival. This is the curve for the intermediate and poor risk group, looking at the PDL expression of high PDL expressors, a very good long-term survival, median progression-free survival, of 22 months versus 5.9 months. And if you look back at the slides I presented earlier on, to have a progression-free survival of 22 months in this group of patients is really very, very good and very exciting. I won't really go through all the side effects. We know that for the use of immunotherapy, 90% of patients tolerate these treatments extremely well. 10% have quite significant toxicities which relate to autoimmune diseases that we generate and we cause because of interfering with the immune system. And the other slide I just wanted to present was the Emotion 151 study. This is the combination of Roche's compound atezolizumab and bevacizumab, again in the first-line setting, randomized to suitant. This hasn't been published fully, but it was presented at ASCO GU 6 weeks ago. And if you look at the progression-free survival in the PDL1 population, it was 11.2 months versus 7.2 2, and there's the intention to treat progression-free survival. This was also significant. Response rates, 43% versus 35%. Sunitinib response rate here is slightly higher than we'd expect, but the combination is very impressive. I've had one patient on this study who had a CR with multiple lung metastases, had a CR, and has been on it for now 2.5 years, and was able to spend 4 weeks sailing around the Irish Sea. She wouldn't have been able to do that if she'd been on Sunitinib. She's performance status is 0, she's maintained work throughout all of this, and has had a fantastic response. There are other studies that are in progress at the moment, looking at different combinations, pembrolizumab plus axitinib, everolimus versus plus lenvatinib, and you can see here nivo versus cabozantinib. These studies will all come through in fruition. These are all first-line studies of novel combinations. But actually, whether or not these are positive, the field of immunotherapy is moving on, and there are much more new exciting combinations with standard immunotherapy drugs, or we call them standard, such as nivo, such as pembrolizumab, etc., but using some of the newer inhibitors against things like IDO, LAG3, etc. So I think this is a really exciting field that's going to open up and is going to change how we manage these patients quite significantly in the future. So this is, I've only got a couple of slides to go. This is the slide I showed you earlier on about all the different treatments. I think this is where we are now in 2018, that these treatments are going to be licensed and they are going to be available for us to use as first line alongside some of the tyrosine kinase inhibitors. We talked a bit about earlier on about potential genetic mutations. I don't have time to go into all of this, but clearly the field also is moving on, and we're going to have to understand the role of these mutations of different genes in understanding and describing the different types of renal cancer. Calling it clear cell, calling it papillary in the future, I don't think is going to be how we're going to do it. We're going to classify them according to their molecular phenotype. I should say that SETD2, which is one of the genes that was mentioned earlier on, is a gene that we're interested in because we're about to start a study of a novel drug in renal cancer for those patients that have a histone trimethylation loss, and it's the SETD2 protein that trimethylates histone K36. And actually we've noticed a synthetic lethality effect with a trimethylation loss of that histone together with using a WEE1 inhibitor, which is AZD1775. So we're just about to start a study for patients along the lines of a SETD2 mutation in renal cancer, which again is quite exciting because it's all new biology. So in summary, we've now had about 10 years of experience of using tyrosine kinase inhibitors. We're coming into a really exciting era with modern immunotherapy, and I think molecular genomics will also transform all of our treatments. I think that's all I've got to say. Thank you very much for giving me the opportunity, and I apologise I've gone over.